Hi, welcome everybody to today's session for the Inpatient National Workshops. We're going to be focusing on the Cultural Competency Programme, which is a fantastic project that Mark has been working on at Birmingham Women's and Children's. He is very much welcoming questions from everybody. So if you have any questions, please feel welcome to pop your hand up or to just pop something into the chat, and we will make sure that they are responded to. So without further ado, I am going to hand over to Mark, if that's okay. And I've got your slides all ready to go here.
Thanks so much, Hannah. Hi, welcome. Just to say that I'm Mark Hillier, Senior Patient Experience Manager at Birmingham Women's and Children's Hospitals. We run two busy hospitals in Birmingham, both specialist and also mental health services for the wider area. My colleagues are just with me as well. So we've got Amy from our PALS service and Carla from our Interpreting and Cultural Insight service. So we'll take you through this so that people who are kind of watching afterwards on the recording can just learn a little bit about the project that PICA have kindly asked us to present to you. So our trust for patient experience includes PALS, patient volunteering and engagement, interpreting and cultural insight, also the survey systems. We collect the FFT and other surveys as well on our portal, but also lucky enough to have arts in our portfolio as well, which is through the kind trust charity that we have. So those are some of our services that we cover. I know it differs from hospital to hospital. So for the inpatient survey for ourselves, this chiefly covered women in the gynae service at our Birmingham Women's Hospital. We also run other PICA surveys at our Children's Hospital and in mental health services. So our results from the 2020 survey, of course, this was a difficult year. It was the year when COVID had taken hold, and that gave us a very different service proposition in the trust. And we did our best to try and shape our services, move some staff around and cover things during that year. The results appeared good on first look. So we looked at them. We scored well in many areas. We'd scored well against other trusts. Being a specialist hospital, I guess we're helped a little bit that we can give a little bit more time to people and offer them some help. However, we decided to look into the demographics a little bit more, particularly as Birmingham is a very diverse city. So we know we have large numbers of people from different ethnic backgrounds. We also wanted to look into some of the other things like mobility, given that the gynae service often helps people in an older age group. Looking into those, we found there was some quite stark differences. So the results that have been given by our white women and women of Christian background were very difficult from the results we had from our women who are Asian and of Muslim background. We also saw some differences in the results for those with mobility problems and disabilities. We thought this was interesting, and this matched some anecdotal evidence we had, matched some of our feelings that perhaps some people are less likely to complain, less likely to fill in surveys of their own volition, giving negative results. And we knew that it's pretty rare to be asked to interpret for our PALS or complaints departments. So despite a large number of non-English speakers and perhaps over 10,000 interpreted appointments in a year, we had relatively few people actually complaining to us. So we felt this probably did match some of the feelings we had as a trust, and we needed to do something about that. So I'll take you through the next slide where we talk a little bit about how we started to delve further. The first thing we did was to try to find more evidence and get more surveys completed with people after their appointments in busy clinic areas. We also looked at doing some telephone surveys. So we picked off some people who'd used the services around the time the survey was done or a little bit before or afterwards. And we started to ask them in their languages what they felt about the services. So using Urdu, Mapuri, Punjabi and Bengali interpreters. We planned 2 focus groups. So that was to bring people into the hospital to discuss things a little bit more. For every person that we phoned, I think we phoned around 70 people, we invited them into a focus group. Now, unfortunately, I mentioned the COVID period and we planned the focus groups, and just before they took place, we entered another period of COVID restrictions where it became more difficult. We had to wear masks all around the hospital in all settings. We realised it was less likely people would come in. But one focus group we managed to go ahead with, and Carla led that focus group. So Carla's going to tell us a little bit about what we discovered in that focus group.
Yep. Hi, everyone. Again, I'm Carla Johnson, Interpreting Cultural Insight Manager at our Trust. Yeah, so as Mark mentioned, when we arranged the focus group, we were hoping for high attendance and we definitely got lots of interest. But unfortunately, the COVID restrictions at the time meant that we had to limit numbers. We did have two women that came and joined our focus group, and it was really insightful to get their experience. One was English speaking and one was non-English speaking, and the difference in their experience was quite stark. We focused the group around key topics. So we were looking at wayfinding, so how easy it was to navigate around the hospital. We were looking at food, their experience of being an inpatient, but also in the catering outlets around the hospital. We were looking at the communication with staff, so how they felt about the update on their treatment and how they felt they were communicated with during their stay, and also the COVID restrictions. So looking at how the restrictions had impacted on their stay at the hospital. It was really interesting the different experience they had. Both of them had commented quite strongly about how the COVID restrictions had impacted on them and during their stay, and how reliant they felt they were on partners to do those tasks that perhaps they didn't feel able to ask the busy staff about. So one of the women commented about just asking for a glass of water that was out of reach. They felt that that was such a small thing to ask a member of staff, but it was really something they felt they struggled with at the time. And had they'd had a partner there with them, obviously that's something that they wouldn't have even had to consider before. So, and also with the non-English speaking woman that attended, communication, again, they, without having that access to more informal interpreting, they did find that that was difficult, and again that's something that we fed back to the teams about making sure that not only do we have interpreters for those updates about the medical treatment, but also access to interpreters for those more informal times that are really important to our patients.
Thanks, Carla. So we continue to increase surveys with our target groups. We did that through asking our interpreters if they could continue to get surveys in people's own languages. And we also used our bank interpreters. We've been using them for a while on the door during COVID. So they would take things from family members and distribute those to the wards where people were, or bring things back down to family members. So they also helped us to increase the number of people we got some feedback from. We decided we needed to make the interpreting services a lot more evident in the hospital, not just for patients or family members, but also for staff access too. So we made sure that a room at the very front of the building was well signposted. We got some large banners printed to make sure that people knew that was the point where they were to come if they needed an interpreter and were unsure or didn't have one. We decided that it was important that family members or patients could book an interpreter themselves. This hadn't tended to happen so much in the past. We tended to rely on staff booking the interpreters for the appointments. Now, there's a little bit of pushback sometimes from some patients who might feel that perhaps they shouldn't have to do that, but we're very reassuring and that we will book you an interpreter for an appointment, but if you'd like an interpreter at another point, or if you feel you want to check to reassure yourself, you can ring us directly. So we gave people business cards with our number and our email address. We increased the number of Dora units. We have Dora is a bit like Dora the Explorer. So we have electronic iPads on stands around the hospital, and these can be wheeled to somebody and will immediately be able to be set up as an automatic interpreter for them. It's a really popular system in our hospital. We realised through the focus groups that perhaps people were a little bit wary of asking, and staff were a little bit wary of handing these out at times when it wasn't a pure medical appointment. So we tried to reassure staff and even offered 2 of these for some departments so they didn't worry so much about using them for informal discussions, reassurance about medication, explanation as to why tests were being done, discussions about discharge, because these were some of the points where people weren't always using an interpreter or an electronic interpreter. We also managed to put some of them onto the 4G network because our Wi-Fi wasn't so good in some areas of the hospital. So we realised that in some departments they weren't using them as frequently as some of the other departments where the Wi-Fi was better. Our interpreters also took time to walk the wards, so to perform ward rounds at certain points of the day, so we could try to get to know patients who might need extra interpreting help. we're lucky that we have bank interpreters, so we can pull on them and use them a little bit more when we need them. Bank like an agency until the trust. We also had interesting feedback from deaf service users. So we had done some deaf awareness, but again, COVID came in and brought extra restrictions. So we had feedback from somebody who'd come, and unfortunately the interpreter didn't meet her at the main reception area. So she had to approach reception and ask her way around the hospital, ask her way to the department for a blood test. And she found that really hard because the staff were wearing masks. This hampered the speech pattern and the ability to lip read. And for BSL users, without a BSL interpreter, it's really, really hard to try to make communication. So we learned from that to ensure that staff must book the interpreter to meet people at the front office at the start of the hospital and not book them to the department, which can be some way to navigate and negotiate. We've changed the name of our interpreting service. So rather than interpreting service, it's interpreting and cultural insight. And we've learned that we've really developed a lot as a team. We've managed to learn so much more about people's culture and how that can affect the way they access our services. And I'll take you to the next screen now, where I'll talk a little bit about our project there on cultural competencies. I mentioned we're very lucky that we have a generous trust charity. So the charity has funded us for a patient and families ambassador for inclusion and diversity. This is a 12-month project, and it's like a project manager who looks at small improvements and larger improvements, things that we can do, particularly on the themes of inclusion and diversity. And we picked race and disability as two really key things to concentrate on that we could improve upon for a large number of our patients. One of the projects is wayfinding. So we mentioned negotiating the hospital. So we're looking at the whole hospitals and their wayfinding. We're looking at what patients call departments, because they often don't call the department the same name that the staff use or the name that's on appointment letters. We're looking at simple maps, audio maps, symbols, and just wayfinding techniques, like we say now, follow the yellow line or follow the green line to take you to somewhere. And it makes it easier as well for our staff to help people navigate, because we found that some of our staff were also struggling to navigate people because departments had moved around, particularly through COVID. Our patient and family ambassador is working directly with patients and families for improvements on black skin and hair products, on how we deal with autism and learning disabilities in our trust, and how we improve the service for people with those backgrounds. She's been able to run some pride table talks. So we had a black table talks when we were going through the process of improving our inclusion and diversity departments and responding to the Black Lives Matter protests. And we've developed that into pride table talks to look at how we work with LGBTQI patients and how we think about pronouns and how we think about their needs when they come into our services. So it's a whole scale look at all of the things that we do and how we can do them better. Our patient and family ambassadors also developed a dedicated inclusion and diversity survey. So as well as the friends and family test survey, we now run an inclusion and diversity survey. So if people want to tell us a little bit more about their feelings about how the trust deals with inclusion and diversity, they can. And we find that having the surveys on a QR code on people's phones, they're really honest about what they're finding, and that's really helpful for us to improve. Our big project was cultural competencies awareness. So we developed a whole scale project looking at how we could make people better aware of the needs of some of our different groups that used our service. So we worked in co-production with partner organisations, and we asked for experts by experience to work with us to develop the training programmes and to deliver the training programmes, so there was added impact from the experts by experience. And they could also take live questions from our staff members on the training and answer for them how they felt from their experience of health services. Often they were local agencies, so they could talk directly about their experience, sometimes of our trust, which was brilliant. Sometimes we used national agencies because they had that expertise, but they still were using people who were very experienced in healthcare. So some of the areas we covered were deaf awareness. So we had a BSL speaker delivering the training. We had mind, mental health, And that's also led to spin-off projects such as mental health first aid training. We had Birmingham LGBT deliver transgender awareness and LGBT awareness. We had the UN Refugee Agency deliver some refugee and asylum seeker awareness training, including with women who'd been through that, so they could tell us directly how the different stages felt to them and the difficulties at different points in accessing healthcare. We had young people with autism, so Ambitious About Autism brought us young people who could talk very directly to our healthcare staff about how it made them feel when they came into our waiting rooms, when they came into appointments, when they had an experience, perhaps they were going into an MRI scanner, and the things that we could do to help and improve upon that situation. We had friends and families of travellers, Roma and Gypsy people, so they were able to give us an experience from two different generations, which was really interesting, and talk to us about some of the taboo subjects in healthcare for their communities. The final one is Acacia, so we're looking at the experience of pre and postnatal depression and anxiety, and we've held on to that one because we've had a bit of a ban on training at the moment because we've been so busy in our women's hospital, but we're hoping to deliver that one in January. And we put together a further bid so we can extend the project for another year. And that's currently with our charities for assessment and decision about the bid we've asked for. We want to keep working with the partner organisations, so we've invited them into our hospitals. We're having them run stalls and meet people in the hospital, patients, families, parents, staff members too. We're finding that really helpful because staff are also learning about the different agencies and what they can offer, and they're passing it on to patients and parents regularly. We need to collect some of the local actions developed by the staff who've been on these awareness training courses. So they're very talked about now in our hospital, in our trust, and we've had probably about 10% of our staff go through at least one of these training programs, and we know they're developing their own actions, their own improvements, their own projects to work upon. So our planning this year is to work more on that and help them with a plan for those, to share them as well amongst other departments that might find them useful. Carla's going to talk to you about one of the biggest spin-offs we've had from the project, where we've introduced a new type of role in our Interpreting a Culture Insight team.
Thanks, Mark. So one of the things that's come out of the Cultural Competencies project has been the launch of a Cultural Engagement Officer role. So this is a pilot that we started in the last 3 months, and it's very much come out of feedback from things like the Inpatient Survey, where we really recognise the importance of offering that consistent language support and really understanding our patients' cultural needs and the impact that not taking those things into consideration can have on their pathway through the trust. So this role we're really excited about because it's the first time we've had someone in post who's able to coordinate the language needs of our patients and families. So they're able to go and work with a family from the very beginning when they first come through our doors, assess their language needs, and be able to feed that back to the staff as well, to be able to kind of say this is what this family will need, and it helps build up that trust and that relationship between the patients, families, and the medical teams as well. It also helps by going that one step further than traditional interpreting because it recognises patients' families will understand the systems and structures within our trust and the importance of explaining that to them, of giving them the opportunity to understand the way that we work, the different uniforms, all of the different activities that go on in the hospital, the different services that are available to them. And all of these things come outside of traditional interpreting, where you would have someone who kind of just comes in for the medical update and leaves. We recognise the importance, particularly because we're a specialist trust, of having someone there who could coordinate all of this on behalf of the patients and families and really be that person to act as the go-between between staff and the families. It's worked out really well, and actually we've had over 88 interventions since the pilot began, and they've been really positive. Families have really welcomed the opportunity to be able to speak to someone about their needs while they are an inpatient, and also it's worked really well for the staff to be able to have a consistent person who's coming and able to manage and be able to tell them this family need another update, this family aren't quite clear, perhaps we need to revisit this area of the treatment. That's been hugely successful in maintaining that trust and that relationship, and I think we're really excited about where that could go in 2023 as well. Thank you.
Thanks, Anne. We can take any questions that anybody might have.
Thank you. So feel welcome to pop your hand up or to drop something into the chat. But actually, can I kick it off? This is a really interesting program. You've got a lot of different elements that have been going on here, and it's very, very impressive the outcomes that you've had here. I was really just going to ask for some advice for kind of the audience. You talked about co-production being kind of a key element of the initial development of what the plans were going to be going forward. Do you have sort of any advice for people that are going through that process of co-productions, especially with people that are experts by experience, or any recommendations?
I think it was really important to work with the right organisations. So we had a bit of a filtering process where if we had a couple of organisations, we met them and sort of just checked out how they would work. And also it was important that they would take some feedback from our organisation. So we tried to help them to understand the sorts of situations that might occur in our hospitals, in our services or departments, so they could tailor the training more to meet what we needed. And that meant that it was really interesting for staff and hooked them really into the sessions. They were all webinars and we didn't expect that. We thought that we would probably do some face-to-face. But because of COVID, we went along the webinar route. So we had to make them interesting to captivate people, to keep them there, and to ask questions at the end, because we really wanted that process of them asking directly to the young people, if it was in the autism session, or to the gypsy or Roma or traveller person in their session. What's it like? How does that work? What did you feel at this point? And that worked really, really well. I think Carla dealt with most of the agencies, so might have a bit more insight into how they chose the people who actually appeared in the webinars. Because for some people that was a little bit, well, they weren't sure they could do that, so they had to like prepare people for that.
Yeah, I think the key thing was making sure that it was rooted in patient experience. So you quite often find with training that it can be quite generalist. So people will be, they'll know about a certain topic, but it can be quite generalist. Whereas we were really looking for the patient experience angle. We're really wanting the trainers to come along and make it relevant for staff so that they could actually identify, maybe think, oh, I recognise that as a situation that I found myself in at a previous time, and how maybe I would approach it differently next time. So that was really important for us, is really making sure that they understood that and were able to give us real life examples for our staff to be able to work with.
I've also got another question. This is one that often gets asked, and I think useful for the audience. The cultural engagement officer, what band is that role in, and is it a full-time role? What's the kind of response been from people on the floor about it?
I'll let Carla take this one because Carla manages our cultural engagement officer.
Uh,
At the moment, it's a 3-month pilot, but we are really hopeful that we'll have a further 12 months by an application to our trust strategy.
Yeah, it's as Mark said, it's been a pilot that we've done for 3 months because we wanted to do a lot of scoping. We wanted to see, because we could recognise the need, we could see from the interpreting department that there was this need to have someone coordinate and be someone who was able to kind of really help and support our families beyond just being there as an interpreter. And the pilot has been much more successful than we actually anticipated. We knew there was a need, but we've been actually getting referrals from clinicians, which has been really exciting for us. They've come to us and said, we're working with a family, it's quite complex, the trust has broken down, we feel like we've run out of things to kind of work with, and we've been able to come in and just take a step back and really understand where the communication has broken down, where the family don't feel that they're maybe as up to date as they would like to be, and to kind of put that all on an interpreter it's not their role, whereas the cultural engagement officer is in a very unique position to be able to kind of step back and really assess the situation from a different position. So it's actually been really popular, and we're really hoping that we do get that funding to develop it next year.